Hello, this is Eliasen, and Kaidra. We are talking about cardiomyopathy. So a definition that the book started off with is really great and we wanted to share. It is, quote, cardiomyopathies are a heterogeneous group of diseases of the myocardium associated with mechanical and or electrical dysfunction that usually exhibit inappropriate ventricular hypertrophy or dilation and are the result of a variety of causes that frequently are genetic. Cardiomyopathies either are confined to the heart or are part of generalized systemic disorders, often leading to cardiovascular death or progressive heart failure-related disability. So right here, we're just going to orient you to what we're talking about. So this is going to be about the heart here, and we have the human body and the lungs here, and the pathogenesis of blood flow essentially is blood coming in from the body to the right atrium, down into the right ventricle, up through the pulmonary artery, out to the lungs, back into the left atrium, to the left ventricle, and out the aorta to the body.
With cardiomyopathy, generally blood is not adequately sent out of the heart to the body and lungs. This causes blood to become backed up in different locations. If there's a problem in the right heart, you have a decreased outflow of blood to the lungs, which can result in a shortness of breath and increased respiratory rate. With the decreased outflow, you then have a backup of blood to the body, which can cause systemic edema, which is swelling, especially in the legs. You're going to see that. If you have problems in the left heart, you're going to have a decreased outflow of blood to the body. Your heart is also going to have a decreased blood supply, which is going to cause the heart to have an increased rate of contraction, and you're also going to experience angina. There will be systemic weakness and fatigue, and then because of the decreased blood flow to the brain, you're also going to have a syncope, which is fainting, losing consciousness. With the decreased outflow to the body, you're going to have a backup of blood into the lungs, which can result in a pulmonary edema. You can hear this with different lung sounds called rales or crackles.
Okay, talking about incidence and risk factors of cardiomyopathy, it's often seen in young adults from their 20s to 30s, which is pretty shocking, but it is, as we're going to talk about later, often seen with a sudden attack and seen with sudden death. This incidence is increased, and that's due to improved technology that we have, which is evaluating the ventricular dimensions and the wall movement. And then we have the diagnosis of catheterization to assess the arteries and valves, echocardiogram, chest radiogram, blood chemistries, genetic mutation analysis, and the ECGs are all tests that are used to diagnose. And then we have the risk factors of increased obesity, alcohol use, and the dosage of chemotherapeutic agents. So the radiation from chemotherapy is definitely taxing on the heart. So we're going to talk about, we're going to break down how we can define cardiomyopathy. So first we're going to talk about the dilated cardiomyopathy. And this is an enlargement of the heart, but the vessels or the walls around the heart are still weak. So that's going to have a decreased contraction. And so there's blood still left into the heart that isn't pumped out. And this is going to be seen in systole most often. Dilated cardiomyopathy is usually due to a genetic or idiopathic component. You're going to hear an extra S3 heart sound, and that's due to the extra blood being left in the heart that isn't contracted out. And so when new blood comes in, you hear a whooshing sound because it's hitting that other blood. Some signs and symptoms of dilated cardiomyopathy are fatigue and weakness, chest pain, and you do see a normal or a low BP with dilated cardiomyopathy, so that's not something that you want to classify on.
The next type of cardiomyopathy is hypertrophic, which is actually the most common form of cardiomyopathy. This is an abnormal enlargement of the muscles of the walls of the heart, which causes a decreased ability for blood to fill the heart or relax. This causes decreased output from the heart of just generally blood being able to get out.
And
with this, you're going to see it during diastole because it's an impaired relaxation of the muscles. It is normally, there's an autosomal dominant component to this disease, and with it, you're actually going to hear an S4 heart sound, which is blood entering a chamber that does not fully expand. That's the sound that you're going to be hearing. You're also going to have a very specific murmur, which is a systolic ejection murmur, which is caused by a turbulent blood flow causing a whooshing sound.
And finally, we have restrictive cardiomyopathy, and this is a rigid myocardium, and this is due to scarring of the tissue, and it could be a secondary issue as well. And this is going to have a decreased relaxation and filling, and this is also going to lead to an S4 heart sound as well, just like hypertrophic, where you have that stiffness that the blood meets and it causes a different heart sound than the regular. And it has that impaired relaxation, which is in diastole. And this is usually idiopathic. It might be a secondary cause. It's something that they aren't super sure on. But manifestations of restrictive cardiomyopathy are related to the cardiac output. And then as that cardiac output decreases and the intraventricular pressure increases, that's where you're going to see the signs of congestive heart failure appearing. So these are all classifications of the old system that are really easy to try and explain, but they do have a new classification system, and it's both primary and secondary. And primary is going to be based on the organ involvement, specifically due to the body itself. It's nothing due to no secondary causes, which are like the myocardial pathology and a variety of generalized systemic disorders that affect the heart and other organs simultaneously. So primary is going to be due to a genetic, mixed, or acquired components, and secondary are going to be due to other causes.
In general, treatment is determined by an underlying cause, which may include physical, dietary, pharmacological intervention of beta blockers, mechanical circulatory support, or surgical intervention, including a transplantation. There is another treatment called a heart jacket, which is still under investigation, and it is a sort of sleeve that is stitched around the heart to prevent enlargement and help with contraction. Restrictive cardiomyopathy specifically has no treatment itself. The only goal with treatment there is going to be to control the congestive heart failure through diuretics, vasodilators, and a salt restriction. But for all types of cardiomyopathy, the only true cure is going to be a heart transplant. With this, there is very specific prognosis if you have the heart transplant. If you do not have a heart transplant, 75% of patients die within 5 years of onset of symptoms. This is due to a diagnosis not coming until the advanced stages or the advanced symptoms begin. Like I said, the only true cure is the cardiac transplant. With a heart transplant, a 1-year survival rate is greater than 80%. Also with the transplant, the 3-year survival rate is 70% or greater. But a 1-year survival rate without the transplantation is only 5%.
All right, how does cardiomyopathy have anything to do with us as upcoming physical therapists? We do want to be well known of the fact that you can have a sudden death. It is very rare, but there is that chance that it could be happening. So we want to know, like, what if a person does fall, like what the possible causes could be, and that it might be a medical emergency. With a person who's in the earlier stages of cardiomyopathy or who is at risk of getting this disease, we want to make sure to be pretty easy on the patient, essentially. Nothing too strenuous, nothing that's going to make the heart function more than it is allowed to or more than is safe. So those are just things to consider, and things we want to be evaluating during exercise is the heart rate and rhythm, blood pressure, respiratory responses, and then have them rate their scale of perceived exertion as well.
So cardiomyopathy is related to the cardiopulmonary top 20 discussion points because the general symptoms are the same as heart failure. This includes dyspnea, which is shortness of breath, orthopnea, which is shortness of breath occurring only when lying flat, causing patients to have to sleep propped up in a bed or sitting in a chair, tachycardia or increased heart rate, palpitations, peripheral edema or swelling, and a distended jugular vein. This is related to the physiological function of the cardiac cycle. Changes in the myocardium change the ability of the heart to fully perform during the cardiac cycle, so whether it's going to be pushing all the blood through. Pathophysiology of congestive heart failure is related because it develops the same type general symptoms as congestive heart failure, which is an inability to fully constrict or relax and in turn meet demands that the body needs of blood. It also is related to the pathologic changes caused by hypertension, because if the body has increased hypertension, then the heart has to work harder, which may lead to hypertrophy of the heart muscle itself.
All right, that's our video. Hope you learned something about cardiomyopathy along the way. Thanks for watching.
Bye.